All right, good morning, everyone. It's 11 o'clock, so looks like we have gotten quite a few attendees coming in. We'll just go ahead and get started with a few introductions as more people come in. I just want to say welcome to everybody. Thank you for joining us for today's virtual panel discussion, Improving Access to Healthcare for Rural Texans. We're glad to be with you today. I'm Karen Brooks Harper, Health and Human Services reporter for the Texas Tribune. I want to let you know that today's session will be recorded. All attendees' lines will be muted, but you're encouraged to submit questions through the Q&A or chat feature, and we'll do our best to group similar questions and ask our panelists if there's time before the bottom of the hour to get to them. Let me start today by thanking today's host, Dr. David Valdez. Good morning. Chief Medical Officer at Molina Healthcare of Texas, and turn it over to him. Dr. Valdez.
Good morning. Thank you, Karen. And welcome guests. Really want to thank you for being part of today's important discussion on improving healthcare for rural Texans. I'm the CMO for Molina Healthcare of Texas. I also am a Texas provider. I work at a federally qualified health center in Valdez, Texas, where we've been serving a number of rural communities. You know, first, I think at this point, I want to hope everybody is safe from all the wildfires that have been impacting our communities. Hopefully, folks haven't been impacted by those. I know it's kind of a little bit of a difficult time. You know, one of the things that we saw during the COVID-19 pandemic is that it really exacerbated the healthcare problems in the rural areas, as well as for folks that have had social determinants of care problems. You know, many healthcare providers temporarily closed or reduced the services that they provided due to staffing issues, and, you know, school, childcare, as well as just a fear that staff and patients would be exposed to the virus. And the net result of that was a decrease in the number of preventive visits, as well as chronic condition management visits. So we really were challenged as healthcare providers to provide the right care that we needed. You know, as a result, Molina and healthcare providers really did rapidly expand the telehealth capabilities. Molina promoted the use of virtual conferencing and, you know, even some telephonic visits. You know, we found that telephonic visits for behavioral health really did increase, and we actually saw an increase in the number of patients accessing that. Again, I saw this firsthand in the federally qualified health center that I work in, and we really do see that it really has changed the way we do deliver some services. You know, as Molina prepares for the post-pandemic environment, our telemedicine and other solutions kind of reflect the lessons learned during this whole experience, some of the best practices, and also what, you know, how we can leverage that we are making sure that optimal health and well-being for our members is being delivered while we advance some health equity in Texas. You know, what are some of the examples of this? Well, I think we're all pretty familiar with some of the flexible, scalable solutions to meet the needs of diverse members, including those who live in rural parts of Texas, like Teledoc. But there's other things coming out, such as e-consults, where a primary care physician may be able to get a specialist opinion overnight, because we know that it's really tough, especially in rural areas, to get access to specialty care. We've also seen a big access in behavioral health telemedicine. And again, it's a service that's very amenable to doing things remotely. We're also looking at expanded school telehealth programs. You know, a lot of great work has been done across the state over the past year and actually 2 years. And our hope is that this panel lays out a little bit about where we've been, as more importantly, kind of where we're going in access to healthcare in rural communities, with a focus on how various sectors, such as healthcare, government, education, and community-based organizations work together to really support and improve the healthcare to rural Texans.
Thank you very much for that scene setter, Dr. Valdez, and thanks to you and Molina Healthcare of Texas, along with the Small Repairs Accord, for bringing together today's expert panelists for what I know will be a timely, lively, and fascinating discussion. Let me introduce them to you now. Panelists. We'll start with Kelly Cheat, Director of the Texas Rural Health Association and Director of Community and Economic Development at the West Central Texas Council of Governments. Mr. John Henderson, President and CEO of the Texas Organization of Rural and Community Hospitals. Dr. Stacey Silverman, Assistant Vice Chancellor for Academic Planning and Policy at the Texas A&M University System. And Dr. Russell Thomas Jr., Family Physician in Eagle Lake, Texas. Thanks for being here. Texas is the most rapidly growing state in the country, adding 4 million people, the most of any state over the past decade. However, Texas ranked 42nd overall in a recent measure of health system performance, in large part because of how hard it is for residents to access and afford the health care they need. Dr. Silverman, I'm going to start with you. Can you provide an overview of the current rural health landscape, including challenges related to staffing, access to care, and the impacts on underserved populations?
Thank you, Karen. Yes, I'm happy to do so. I'm so pleased to be part of this important panel today, and I'm just honored to be with the rest of this group of experts and just to acknowledge that we've been doing work in this space for many years, and some of us many decades. And just to amplify what you just mentioned, Karen, I'll just note that Texas is, in fact, the fastest growing state in the country. More than 1,000 people move to Texas every day. Notably, from 2010 to 2020, the population of Texas increased by 16%, more than any other state. And even though California remains a larger state in terms of sheer numbers, the population growth in Texas was well more than twice that of California. And even though our population grew so rapidly, it's a very different story for our Texas rural communities. While Texas has become more urban, as of 2017, approximately 170 of Texas' 254 counties were identified as rural, representing 70% of Texas landmass. And it's notable that we have 24 fewer rural counties than we did in 1997, but it's also a concern that 86% of our 254 counties experienced a loss in numbers over the last decade. Interestingly, the total population of rural Texas has remained relatively unchanged for the past 20 years, at just under 3 million in 1997 to just over 3 million in 2017. But Texas continues to have serious healthcare needs in its rural areas. Even in the pre-pandemic era, Texas rural communities had difficulty accessing healthcare services because of travel time, limited healthcare providers, and high rates of underinsured and uninsured residents. Compounding this is the reality that rural Texans have fewer financial resources. They're less healthy than their urban and suburban counterparts, and access to healthcare services is a challenge, as evidenced by the reality that Texas led the nation in the number of rural hospital closures since 2013. I know COVID placed an unparalleled stress on all of us, but its effects on rural communities is really notable. Some issues that emerged were most notably the lack of access to broadband and the need for more healthcare workers. As I previously mentioned, rural Texans are older, poorer, and sicker than folks living in urban and suburban areas. Unfortunately, this often means patients wait longer to seek care, and they may be sicker when they do. And the reality is there's just a limited access to care once they seek it. Distance to receive healthcare has long been the norm in rural Texas, with drive times of more than 2 hours from one community to the next to receive just regular healthcare. That's not uncommon. But I do believe that there are new innovations, and COVID did teach us some, I think, incredibly important lessons. Most notably, as Dr. Valdez mentioned, the use of telemedicine and telehealth and improving connectivity. I think these things are essential to improving the healthcare in rural Texas. And I know challenge is nothing new to our rural Texans, and they are resourceful, resilient, and I am confident there are also new solutions to help address longstanding healthcare issues in these areas.
Thank you, Dr. Silverman, for that comprehensive answer. That was a great way to start our conversation today. Dr. Thomas, can you give us some examples from your family practice in Eagle Lake of what you're experiencing as a provider in your community and what you hear from patients about their challenges to receiving the care they need close to home?
You bet. Thank you for having me today, and I apologize for bringing my cedar fever voice with me. Just to reinforce what Dr. Silverman pointed out, 1/3 of all motor vehicle accidents occur in rural areas, but 2/3 of all motor vehicle accident deaths occur. Now, the thing about it is that if you're going from Houston to watch the Longhorns play or the Aggies play, even if you're an urban person, for a large majority of the time, you're in a rural area and you are a rural citizen. So it impacts people even if they don't call a rural area their home. Certainly what we see in my community and in most rural communities, I think, is that the access to care is challenging. The number of providers that we have is limited. And if we lose a provider, as our practice is about to, that makes a significant difference in access to care. On the one hand, we're able to provide pretty good primary care out here, even to those who lack resources. We find that issues occur if they require a higher level of care, either because of an emergent thing where EMTALA may help out, or non-emergent things like coronary artery disease. Even someone who comes into our hospital with a pneumonia that starts out simply, once they're admitted, if their pneumonia turns into something more significant, EMTALA is no longer in effect, and we're frequently unable to get those patients to a higher level of care. On top of that is the fact that while over the past several years we haven't had many rural hospitals close, over the previous 5 years, I believe we lost 22 rural hospitals in the state of Texas, including 2 within 30 miles of Eagle Lake, which has stretched that time to care out even further. My patients are challenged to get in to see the specialists that they need for problems such as orthopedic surgeries, neurological problems, cardiovascular issues, things of that sort. We have been fortunate over the years to have a small cadre of specialists who give up their time in the city and come out to work in our clinics once or twice a month, but the access is still challenging. And with the limited, those guys in the urban areas have limited programs that they participate in. Many of them do not participate in any of the Medicaid type programs, which makes it extremely difficult for us to get those patients in for any sort of care. So the challenges, even in spite of what we've had to put up with COVID, have always been there as far as access of care, especially to specialty care, especially for people who need a higher level of care after presenting perhaps with less of a significant problem. Telemedicine has helped somewhat, but the difficulty with access continues to be there, even with the telemedicine.
Dr. Thomas, thank you. John, from your perspective, what are the most important resources and tools that hospitals, practices, EMS providers, and others need to recruit and keep doctors in the rural areas where they're needed? John?
Yeah, I've got 3 or 4 ideas that I'll share, but first I want to say thanks for having me and maybe build a little bit on Dr. Silverman and Dr. Thomas's comments.
Yes.
They're exactly right. There are 3 million rural Texans, but that's roughly the population of Arkansas. So rural Texas alone would be the 34th largest state, and every Texan matters, as we like to say. And although Texas has led the nation in rural hospital closures, I'm going to knock on wood because we haven't had any in a little more than 2 years. The last rural closure was in January of 20 in Bowie, Texas, which is up between Wichita Falls and Decatur. Pandemic has been hard on everyone, but our rural hospitals universally have met their obligation to their community and in some cases endeared themselves better to their community. With regard to Dr. Thomas's comment about the trauma system, we remind people it's not where you get your mail, it's where you have your event or accident. I can be an urban patient and urban citizens can be rural patients if they're on their way to the ball game or the deer lease or summer camp. So the trauma system matters for everyone. Specific to the question you posed to me about resources that help recruit doctors or EMS providers. I think the best tool probably is loan forgiveness programs for folks that choose to locate and serve in rural areas. The most common at the federal level is called the National Health Service Corps. At the state level, we had a great program called Outstanding Rural Scholars that was in the Texas Department of Agriculture, specifically the State Office of Rural Health. But during a tough budget cycle, that the funding was cut off. So we hope during the next session to restore some of that, either in that office or somewhere like the Texas Higher Education Coordinating Board that does some loan forgiveness for nurses. The other thing we need to do is more residency slots. Dr. Silverman may be able to speak to that. I think we're making slow progress there, but I hope we can do more. And then the last thing I'll offer up is homegrown. We believe strongly that you can recruit physicians and make any kind of situation work if you're welcoming to people. But best case scenario in our experience is if you can find and sponsor a local kid or spouse who's smart and has a stake in the community and roots in the community, get them back to the community. And especially if they have a mission or for the purpose of the hospital or clinic, then that's a home run, and you should be doing a happy dance about helping that kid get through school and come back home.
Thank you, John. Kelly, can you give us an overview of what you're seeing in terms of the biggest challenges in West Texas in regards to overall community health?
Of course. Again, I appreciate the opportunity to be on the panel with the other guests. It's great to kind of hear their expertise. And of course, John and I work closely together on projects. West Texas is, of course, unique. We're an aging population. Our population, we're losing young folks, young individuals to other parts of Texas. But those that are still here still need access to care. We did see a couple of, we've seen a hospital in our region close over the past couple of years. The economic development and the healthcare, they go hand in hand. And so you can't really promote one without the other. And so from our job, working with these counties, you've got to have a strong infrastructure. And I go back to the aging population, but we also have an aging infrastructure. And so I think it's important that we continue to work to try to find resources. A lot of federal dollars are coming down the pipeline through economic development programs and other programs that I think communities need to utilize. But the broadband, I know it was mentioned earlier with Stacey, that pretty much impacts economic development, rural healthcare, everybody. And so when you're trying to recruit like young folks, individuals to come back home and work remotely and raise their family, that's the things they're looking at. And are they going to have access to the broadband? Can they work remotely from their company in Austin or San Antonio? And so I think there's a lot of pieces, but again, it's work with all the different factors and trying to find solutions. But rural Texans are resilient. They always are trying to work through things. The pandemic's shown us that. They got knocked down, but they got back up. And so I think there's just a lot of different pieces.
Dr. Thomas, thank you, Kelly. Dr. Thomas, we know that the COVID-19 pandemic had a major impact on medical professional burnout, further exacerbating care issues we were already seeing across the state, especially impacting rural areas. I think we've talked about this in this panel already a little bit about the personnel problems. In your experience, what changes can be made to ensure medical professionals are incentivized to stay in local communities?
Challenging question with a lot of potential answers, I guess. Certainly the impact of COVID has been felt significantly in the rural areas. The comment I made earlier about being able to send people in for a higher level of care. We've all become experts on ventilators out here over the past 2 years because we've been unable to send patients into the city, and those added challenges have made it difficult. In fact, we are losing one of our 3 physicians in my office in part because of the COVID episodes, if you will, and the stress that applied, plus the fact that our small hospital had to give up obstetric services, and she had to start doing her OB at another hospital, which doubled her call responsibilities, making it extremely difficult for her to continue to raise a family and carry on a practice. It's certainly understandable why she had to leave under these, or chose to leave under these circumstances. I think that, you know, you're not going to find somebody that comes to the rural area because you get paid a lot. That's not to say that you take a vow of poverty if you come out and practice in the community. But I think, as John pointed out, some of those other options, loan forgiveness is a great thing. Access to other professionals, enlarging the community above and beyond just primary care physicians, and access to those people, which certainly can come about if we all work to develop a more robust telemedicine program where we can deal with specialists online. Having access to specialists when it's time to move a patient up the road, rather than leaving those patients back here and applying that extra responsibility to the primary care physician, is something that we need to look at dealing with as well. I think at the end of the day, access to care, homegrown, is critically important. I'm from Eagle Lake, and that's where I'm practicing. We have two physicians in another community that are part of our group. One's from Anahuac and one's from Garwood, which is half the size of Eagle Lake. And the fourth physician is from Mission, and his wife is from Columbus, which is 15 miles up the road. And I think the reason that they stick around is because they understand the great parts of rural medicine, as far as having a direct impact on your patients, a direct impact on your community. But to incentivize those patients, we need to make it easy for them to get here. They need to be made welcome. We need to make sure that they have access to the resources that they need, be that nurses, educational opportunities, backup. There's a lot of communities that don't have a 5-doctor call schedule like we have here. And, you know, those doctors end up in those communities having to cover all the time. And that can hasten the inevitable burnout that will happen in those cases. You know, in our case, as I mentioned, we're about to cut our total medical staff by 20% and our local by 1/3. That's going to add more pressure on each of us to cover more call. And that will be a disincentive to someone coming down the road. So we need to make sure that there's adequate support and adequate coverage for those who are interested in coming out. And we need to try and get those people that have that interest and have that previous rural experience into the community, whether it's because they grew up here. I'm involved with the Rural Scholars Program at the University of North Texas, where we get kids out for 3 months at a time, and they spend a lot of their rotational time in more rural settings. At least they have an understanding of what to expect when they come out, and hopefully that'll incentivize those that are truly interested in coming out.
Thank you. And that's a great segue into the next question that I have for Dr. Silverman, which is, what is Texas A&M doing, and what can other education institutions do to build a strong pipeline of medical staff in rural areas?
Thank you, Karen. I think Dr. Thomas was spot on to highlight getting in recruiting students from rural communities who want to go back out into rural communities. It's key in order to get that rural pipeline of healthcare professionals out. It works for medicine. It works for nursing as well, as well as with other health professions. A&M University institutions have a long history and continued commitment to support rural Texans, and in developing degree and certificate programs that encourage the development of a rural workforce. And this is especially important for developing a healthcare workforce. For many years, the College of Medicine has worked actively with the A&M member institutions to recruit high school seniors and second-year college students to consider careers in primary care medicine. This is the Partnership for Primary Care. It was established back in the late 90s. And it really serves as a conduit to get those students in and consider practicing medicine and practicing primary care, and then making sure that those students are from a rural or medically underserved area. I'll highlight a couple of other programs that are out there. One that John mentioned, we do have one, and Dr. Thomas mentioned as well. We do have the, at the Texas Higher Education Coordinating Board, there's the Physician Education Loan Repayment Program. And it has, you know, unfortunately, it's subject to the ups and downs of the budget. Funding was restored somewhat to that program. And I think it's critically important that programs like this have strong and lasting funding sources. And I can say that now because I used to work for the Higher Education Coordinating Board, but now I don't. So I get to tout some of their programs in ways that I wouldn't have done in the past. Additionally, I want to just give a shout out to the Joint Admission Medical Program, which was established back in 2001. And it's really a pipeline program that provides a guarantee to Texas Medical School to participating JAMP students who successfully complete the program. It's a rigorous program, but it was an effort back with the recognition that most of our medical schools at the time were getting students from A&M and UT Austin. And really the JAMP program really is an effort to get those students from West Texas A&M or Tarleton or Commerce or Kingsville to think about going into medicine, and giving them the platform and the resources and the tools that they need to successfully enter medical school and then make it through. And then finally, I'll just mention, and I think John mentioned this a minute ago, that we've got, shout out and big thank you to our Texas legislature for back in 2014 creating the GME expansion programs. I will say that Texas has opened a lot of medical schools in the last 10 years. And really our legislators recognize the need to also additionally create new residency positions so that we would not ship our medical school graduates out of state to do their residency training. And I'm very pleased to say that we're on track to meet the state's goal of having 10% more first-year entering medical residents than medical school graduates. So those are just a couple of things that I think are important. I will highlight the other thing, which is that it's very important to get those students from those rural communities into these health professions programs. And I do think that distance learning is going to help with that as well. So I think it's been something that's been a bit of a game changer in recognizing that, what we can all do things online, and we can all none of us knew how to do a Zoom call, I suspect, 30 years ago, but now we're all pros. So I'll stop there.
That's true. We all had kind of a crash course in that, didn't we? Kelly, can you talk about TRHA's high school telemedicine program and how young people can make a difference in addressing the current needs of patients across Texas? How is support from the private sector enabling you to expand the program?
Sure. Again, from the Texas Rural Health Association standpoint, we were excited that we received a grant from the Molina Cares Foundation to expand a telemedicine program for high school students. Let me back. The telemedicine program actually originates from Texas Tech, the Health Sciences Center. One of the things I do is oversee the Area Health Education Center regional grant for our 28 counties out of Abilene. And so AHEC is a wonderful tool that's been around for years. It's receives federal and state funds. AHEC's come through medical schools. And so in our case, we're of course with Texas Tech. And so Tech created this telemedicine program about a year ago, and we operated through AHEC's. And it was a chance for us to actually go out into the high schools and work with rural students and give them firsthand exposure on how to use telemedicine equipment. It's a certificate of completion that these students receive. They go through modules and trainings. We had great success in the first year of the pilot program. And so with TRHA's partnership with Tech out here in West Texas, we were able to apply for those funds to expand that program further into other schools. So we're looking at identifying some very rural communities out in West Texas, like Presidio, Sudan, and giving those students just another tool to take with them. Because, we keep talking about growing your own. That's AHEC's motto. That's what we strive to do. We want to work with those high school students. We want them to be aware of the opportunities in healthcare. If they do go off to school, we want them to come back and practice like Dr. Thomas does in his hometown. And there's other jobs out there that are just as vital and important for these rural communities. So again, it's really, we need to tap the resources and the talent we have already in these communities. And so through this AHEC programs, we can do that. And so this telemedicine program will just be one more piece for them to take with them and hopefully come back once they receive their education.
Thank you, Kelly. John, how is telemedicine changing the landscape of healthcare for rural communities, and what are its advantages and limitations compared to traditional care?
Sure, we're careful in the way we talk about telemedicine. It's not a silver bullet. It is a game changer for access to care, particularly in situations where it's non-procedural specialty care, which most rural communities don't have, or behavioral health. I talked to MD psychiatrist that says there's nothing I can't do through a screen that I would do in a face-to-face visit. So for those applications, telemedicine is awesome. The limitations, though, are within procedural-based specialties, and I think primary care, not that you can't do some of that virtually, but most people want to see their primary care physician and have that face-to-face interaction and touch. Another limitation is broadband, even though we're making progress on that in Texas. I think that's been referenced before. And then the third limitation that I want to mention is just the Medicare program and a permanent solution. The telehealth flexibilities are tied to the public health emergency currently. Texas Medicaid is actually ahead of Medicare in this regard. We passed HB4 to allow telemedicine in Medicaid, but the federal government has yet to work out a solution past the public health emergency.
Dr. Silverman, are there any upcoming legislative activities you're keeping an eye on, given the implications they'll have on rural health in Texas? And what legislation would you like to see to help address these issues?
So yes, our legislature in Texas convenes every other year, and they'll meet again this coming January. So I am always going to want to follow what they do, and I really think that supporting the existing programs that we have that are doing well is something that we don't talk a lot about. So getting funding for those loan repayment programs, getting support for the GME expansion, I think are critical. I also think it's really essential that we get funding support to continue the broadband work that's been going on, and to recognize that we've got to make sure that we connect to our rural communities and ensure that they have the resources that they need, and not one size fits all for our rural communities. We always need to remember that as well. But always watch the budget. I'm of the opinion that is the most important thing. It is the only thing the legislature has to pass is a budget, and I will always watch that very closely. So I'll end there.
Hey, if you don't mind me interrupting, Karen, the good news as it relates to the 2023 legislative session, I think the last comptroller estimate I saw was that we expect a $25 billion budget surplus, and that probably only goes up when we have $115 a barrel oil. So the state of Texas at the moment has some money to address some of these rural and workforce challenges. So I think that's worth noting as an opportunity. And with specifically to broadband, most hospitals and clinics and even school campuses have fiber. At this point, it's more about how do you get to the home, you know? And when we talk about telemedicine and virtual school, it's more about broadband access beyond those hospital and school campuses in rural Texas.
Thanks very much for that. And the panelists, of course, should feel free to, you know, kind of bounce thoughts off each other too. I think it's a great discussion we're having. So thank you for that. Kelly, back to you for a minute. Can you talk about well, you kind of spoke with us a little bit about the AHEC program, some, but I want to get back to it a little bit more if you don't mind. Just kind of go deeper a little bit on how it's relieving stress on hospital ERs in rural areas and how it can be replicated or scaled across the state.
Well, in the sense of with AHEC, again, it's about how can we work to try to recruit future employees in the for the rural communities. And so we go into the high schools and we talk to the students. We try to tell them as much as possible what all is out there as far as health careers. And we hope that they will, you know, gather the information, pursue their career, and then of course come back and practice. That's kind of the key. You know, again, I think that's the easiest approach. Like John and them said, you've got to, I think, really try to recruit locally. You can do all the recruiting in the world in Dallas, Fort Worth, but if someone's not familiar with Rotan, Texas, or Fisher County or Scurry, you know, it's a hard sell. And so, and there's a lot of really wonderful opportunities to take these students, to give them the resources they need, help them find the school, find the education, and then come back and serve their community. I mean, I think it's a great story when that happens. And, you know, again, AHEC is kind of that starting place. We work with the high school students. We even go down sometime into the middle schools. It's a great use of federal and state funds. It's one of those things that I think everybody on either aisle of the political landscape would promote and agree with. And again, you know, it's sometimes one of those hidden programs. I think a lot of people do understand what AHEC does. We of course got West Texas, East Texas, South Texas. We all receive funding, but our West Texas AHEC covers 105 counties out of Lubbock. We got 6 regional offices, and so we do a lot of work. But we also do depend on a lot of other resources like John and other organizations. And so again, it's just kind of that mentality. Let's grow our own, and let's expand those programs for funding so we can attract these individuals to come back and practice.
Hey, I'm kind of laughing as Kelly talks because I had a local physician that would say, you know, John, all of our patients are rural, but some of our patients are very rural. And, you know, it's a matter of degree. Rotan and Sudan and Presidio are very rural geographies of Texas. And it's hard to attract allied health professionals to those communities. But at the end of the day, and this may not have been true throughout the pandemic, hospitals and clinics were a really hard place to work. But generally speaking, these are good local jobs with benefits that can't be outsourced, where you can not only make a pretty good living, but have purpose. It's a service industry that appeals to a lot of students. So we've got to leverage that as an opportunity for rural workforce.
Which brings us back to Dr. Thomas. This is your opportunity to evangelize about what you love about your job. Speak to the benefits of providing care to smaller communities, please. How is your career impacted by your choice to practice in your hometown as opposed to a big city? You said that you are from Eagle Lake and you now practice there. So tell us why and how that's you know, any regrets, any good things?
Well, you know, that old saw, if you love your job, you'll never work a day in your life, has certainly been true for me. For the most part, my dad was born in Lissy, Texas, which is 6 miles from here. He practiced medicine here for 40-odd years, and I practiced with him for the first 17 years of my practice. Then I decided that I'll just call it my middle-age crisis to get involved in medical education, and actually moved to Austin for almost 3 years and was the director of the family practice residency there. So I got the opportunity to experience urban medicine firsthand. I tell people that the second best decision I ever made was to take that residency director job because I always wanted to do something like that. But the best decision I ever made was to move back to Eagle Lake. You know, it's also been said that you shouldn't practice with your family. I practiced with my dad for 17 years, and it was the best 17 years of my practice. And you shouldn't practice with friends. And I can tell you that there's no greater feeling, no greater emotion than if you deliver a baby of someone that was your high school classmate, or if you deliver the baby of a baby that you delivered. I did over 2,000 deliveries in Eagle Lake. I can't name them all, but I can tell you I knew all of those people as more than just patients. Now that I'm more, if you will, towards the twilight of my practice, fortunately and unfortunately, I'm having to be there when people are at the end of their lives. And while it's as sad as the delivering babies was exciting and happy, it's very important and it's very profound to be there for those people and their families, to understand where they've come from, where they're going to, and to help them through that process. And by knowing them as members of the community, Eagle Lake has 3,500 people, so we know everybody knows everybody. But by being a part of their community, being a part of their lives outside of the practice, has made the practice much more rewarding to me, and a much more than a job. I have not regretted a single day of the time that I've spent in Eagle Lake. It's been a great thing. I think it's important that people have to be drawn to that. If you're kind of put offish and you're not real interested in having that type of relationship with your patients that goes above and beyond the doors of your office or the hospital, that's the guy that probably doesn't need to look at a rural setting. But I just think that being involved all the way around is the greatest thing that a person can have. And it's been a wonderful almost 40 years of doing this job.
Thank you so much, Dr. Thomas. Back to you, John. Can you talk about what a clinically integrated network is and how it's being deployed across Texas to close these gaps in care many patients are grappling with?
Sure. So the CIN, we have a tort CIN, and it's certainly not the first, but it's a structure that's recognized federally as a way for hospitals or clinics to work together. Once you are connected, you can share not just quality data, but best practices. You can actually collaborate in contracting, which is a problem for these standalone independent rural Texas hospitals. So thanks to actually Molina Cares and some infrastructure funding, we don't know exactly what this thing's going to become, but we're working towards this concept of clinically integrated network. And to me, some of the most exciting projects are those not where you say begin with the end in mind, but say, we've got a group of willing people that are willing to take the next step along this journey and see what we can build, knowing that at the end of the day, we're better together.
Thank you for that. We have some time for an open discussion now. I'd like to end the discussion with an open dialogue among the panelists about the single most important factor, in your opinion, to address gaps in care in rural populations across Texas, including what support you need to be able to make progress. Dr. Silverman, let's start with you.
Sorry, I was muted. Had to say that at least once during this call. So I'll just build on what John just mentioned, and really the importance of connecting both the hospital, the educator, the educational, whether it's the high school or the community college or the university within that region, and ensuring that they're working collaboratively and working to innovate. And I say that, and I think to myself, you don't necessarily need, every hospital doesn't need a nutritionist, but probably one could be shared among 3 or 4 different hospitals out in a rural community. And how can you do that? I think the innovation that we've seen with the establishment of having a sole family medicine doc who decides to open up a FQHC And suddenly, as patients have access to behavioral health and dentistry, I think those kinds of examples are critically important. And I think ultimately they're all about communication and education and connecting. Just as Dr. Thomas spoke about, he's part of that community. Everyone knows him there. Everyone knows him across the state anyway. He used to be on one of my advisory committees many, many years ago. But to get to know that leader group and get them together and get them thinking through new and innovative ways to do things. And again, I do, building upon what Kelly said, that the whole idea of working with AHEX to create new ways to become whatever healthcare provider is needed in that particular area, working with our high schools, working to get students to understand the skills that they need to enter the health professions as early as they can. Get them on that pathway so they're out and contributing to our rural communities. I know I drive to Colorado at least once or twice a year, and every time I do, I know I'm driving through some counties that don't have a hospital, don't have an EMS service, and I'm pretty careful when I drive that way. I don't know that everyone knows that. So I think part of what we can do is educate our urban and suburban folks to be mindful that they are rural when they're out in rural Texas. So.
Thank you. Kelly, maybe you want to jump in, somebody?
Sure. That's kind of it's a tough question. And of course, there's a lot of gaps, but I think it goes back to the fact that we can have discussions like this. I think, there's so many resources out there. And I think from our standpoint and our positions on this panel, I think it's important that we work with our communities and our partners and let them be aware of what funding's out there, what policies are going to be impacting them. I think it's a lot about just having an open dialogue. And so I think the gaps are there, but I think they can also be met if we just, work as one voice, I guess. That's kind of what, we tend to say, especially when we're out here in the rural communities. But we need to look at the different resources. You talk about UNT with the Rome program and how they are focused on rural practices and they're placing students or medical students out in the region with folks like Dr. Thomas and others. I think the more we can talk and the more we work together, I think we'll have a lot of success and just not be forgotten out here in rural Texas, and hope that the state and federal government, create policies and legislation that is meaningful and important, and it benefits rural Texas. And so we just have to, I guess, band together and just kind of let's try to close the gaps.
The gap I worry about at the moment, Karen, is workforce. And I think that's going to be the prevailing issue for all healthcare, urban, rural, everybody for the next 5 or 10 years. Kelly mentioned Presidio, and it's just an anecdotal story, but the hospital in Alpine, I think, is about 70 miles away in the nearest place to deliver a baby. In the hospital in Alpine, but not because of Medicaid funding or anything else, simply because of nurse staffing issues, has gone to a part-time OB service. So they'll deliver your baby Monday through Thursday, but if you come in labor, which deliveries are a hard thing to schedule, on Friday evening, they make a decision whether they can safely manage that delivery in the ER or transfer you by ground ambulance to Fort Stockton, which is another 70 or 80 miles, or fly you to Midland or El Paso. And that gets scary and probably doesn't result in great outcomes. So those are the kind of gaps that we've got to be working on. And I think it starts with matching the local need with the workforce.
And I'd point out, one of the things we haven't mentioned a lot of is it's important for us all to be in lockstep when it comes to things like financing, et cetera. Eagle Lake is a critical access hospital. It is a hospital district. We have UP, we have every little thing that you can imagine to receive funding. And if any one of those goes away, the survival of the hospital is critically at risk. And I think it's very important, not only for those of us who are involved in this discussion, but for those that are perhaps listening in that are part of the legislature and other areas, to understand how critically important all of that is. And what can appear to be a small program at the end of the day could be the difference between life and death for a place like mine and other hospitals out there. We need to make sure that the facilities are there for us to put physicians and providers in. I'm also concerned about, the thing that came through COVID was the need for nurses. And right now, what we're experiencing in Eagle Lake is a lot of our best, most experienced nurses elected to go do contract work in other states where they're making 3 and 4 times the amount that they could make staying in Eagle Lake. Are they going to, when this is all over, are we going to be able to afford quality nurses, or has that paradigm or whatever shifted because of this? And what are we going to do to fill in those gaps? We have one respiratory therapist here. During COVID, we were fortunate to get some from the state and from other places, but what's going to happen after all of this is passed and the emergency is done? The urgency, especially the staffing urgency, is still going to be there.
Thank you. That's one of the key issues we've seen throughout the pandemic is that nursing, the staffing issue, but also the nursing, the contracts and the travel nurses. It's been a very big deal. So thank you for bringing that up too. I would like to now bring Dr. Valdez back into the discussion here. Dr. Valdez, are you with us?
Yes, thank you. Can you
Hi.
a little bit of connectivity problems?
That's why I'm checking on you. I know you're present. I just want to make sure that you're able to connect.
Thank you.
A question for you, Dr. Valdez. Thank you again for coming back. Can you talk about how Molina Healthcare of Texas is working with partners around the state to improve the gaps in rural care? Now, winding up our solutions section here.
Sure, and again, we some of the panelists commented on some of those opportunities that Molina is taking advantage of. The Molina Cares is partnering with the Texas Organization of Rural and Community Hospitals, or TORCH, to advance rural health and really try to look at clinically integrated telehealth and also data analytics. So much of what health plans, the state, credentialing organizations are looking for is analytics. How is your hospital, your medical group, the community performing? Funding will support the development and planning of a scalable, interoperable rural health network. Also expand, the support for the organization's clinically integrated network. Additionally, TORCH is going to convene regional executive roundtables to drive collaboration and identify best practices, because you don't want to be reinventing the wheel. If somebody has a really great idea, being able to expand on that. Things such as shared services, to minimize overhead. If you have a specialist that's really good at something in a certain operational ability or administrative ability, kind of lending that expertise to somebody else, or have as a central resource. Also, physician credentialing. Credentialing has gotten very complex. Getting the timeliness of getting providers credentialed, especially in rural areas, is critical. Once they attract somebody, they need to get them on the panels of the local payers, local and national payers. Through this support, we're hoping to expand the operational capability and capacity of rural hospitals and ensure they have the resources to serve patients in rural Texas and stay in business and to be successful. Additionally, the Molina Cares is supporting the work of the Texas Rural Health Association to expand the availability of that telemedicine technical certificate program. And this will enable them to bring one-of-a-kind training programs and the first telemedicine certificate program to as many as 9 high schools around the West Texas region. And again, if you get kids involved early and let them understand, kids are very tech savvy. Sometimes they'll probably teach you a few things how to improve your systems. That's really a way to get folks engaged. And medicine has become a very technological process. So really think that that's going to stimulate, again, some of the kind of grow your own opportunities.
Great, thank you so much. So the challenges facing healthcare access, as we've learned today in rural Texas, don't just affect 3 million full-time rural residents, but they affect anyone who happens to be in rural Texas when they need healthcare. In short, they are challenges that affect all 30 million of us Texans at some point. As we also learned today, some of those mountains to climb include the lack of access to trauma care, difficulty in keeping medical staff, doctors, nurses, and others battling burnout, as well as attracting and recruiting healthcare workers and physicians to these rural areas, among other layers of gaps and issues that faced by rural Texas. Our panel has had some great ideas for addressing some of these: open communication and working in lockstep on funding, supporting technology and broadband, equalizing access to telemedicine, specifically in some specialty areas. And they've also given us a lot to think about in terms of investing in our rural youth, finding that passion and talent that is growing up right now in our rural communities, helping them pay for a medical education and healthcare, and then incentivizing them to come back home to practice. Lawmakers can help by funding for loan repayment plans, broadband connections, and more when they convene next year with what may turn out to be a pretty big historic budget surplus, which always makes things exciting. Certainly draws people out. I'd like to turn right now to the audience for, looks like we have a little less than 5 minutes of Q&A. I'd like for you guys to use your chat or Q&A feature for the questions. And we're going to be having someone with Monument Group screening for me. So let me see if those are coming. Are they coming? Oh, great. Good. They're coming. Good. Dr. Thomas, this one's for you. Have you been able to recruit the UNT rural scholars to come back and practice?
Have I? We've had moderate, I think they've had moderate success. I'm actually going to be up there this Friday, and I'm looking forward to checking out those numbers. My suspicion is that probably about 25% of them go into some type of a rural setting. It's certainly not 100%. One of the messages that I try to bring to those students is we need radiologists in the rural area. We need surgeons. You don't just have to be an old country family physician to provide that service out there. I think that their numbers are good. It tends to be, while that encourages them into rural areas, the ones that tend to come out are those that were raised in a rural setting, those that came out of an urban setting and then for whatever reason, be it romantic or otherwise, thought that going into the country would be a nice thing, aren't as likely to come out.
Now, this would be for you and for some of the others too, but are rural hospitals easing the restrictions for medical students to rotate? That's something that I've heard a little bit about. That's an audience question.
Yeah, we have no problem, obviously, or perhaps not obviously, but my hospital is going to let my students be actively engaged. Our hospital actually provides the housing and the meals for students and residents that come out, and we actively involve them in every aspect of the practice with and haven't had any problems at all. The patients appreciate students. I think the patients feel like they're getting something special when that student's in there spending extra time, and it has never, ever been a problem here.
It was probably a problem or a little bit of a bottleneck during the worst of the pandemic, where we actually had, faculty, sufficient resources in the programs, but they weren't able to do the clinical instruction on site in rural communities simply because we couldn't have students in isolation areas during COVID. But Dr. Thomas is right. That is mostly gone, and we're encouraging our hospitals and clinics to accept those students for clinical rotations in a rural community, to orient them to it and use it as a recruiting tool. So that there was a time where that was a problem, but it's mostly resolved.
That's a great question and good information to have. I have one more question we have time for. If you had one ask for next session, would it be workforce related, legislative session? Would it be workforce related, loan forgiveness, residency funding, Medicaid reimbursement tweaks? What would it be? One, you get to pick one and you have 2 minutes. Let's start with Stacey Silverman. Dr. Silverman, please.
So I'm just going to put it out there that it's essential that we continue to support the GME, the Graduate Medical Education expansion efforts. And this is like picking your favorite child. I only have one child, so I get to pick her all the time. But you've presented me with 4 children, and I would say that they're all important. So
I have 3 kids and I love them equally. But since the legislature actually has been decent to rural providers when it comes to Medicaid payments and OB payments, even broadband and telehealth, my pick would be workforce, specifically new funding for some of those rural loan repayment programs.
Kelly, what about you? Anything to add, you or Dr. Thomas?
Or I think making sure that the various programs for funding are intact and workforce.
I think the workforce is key. I think that's the most important.
That's really where we've kind of landed on and kind of keep coming back to is this workforce challenging. So we'll see how we can how that moves forward as we go into this next phase of the pandemic. Dr. Valdez, I want to turn it over to you, but first I want to thank everybody for being here and for allowing me to participate. It's been a real pleasure being with everybody. Dr. Valdez, turning it back over to you.
No, thank you, Karen, very much for moderating. You know, I certainly, some of the topics that have been discussed resonate with me in the federally qualified, but also energize me that a lot of smart minds are really working on ideas and are at the forefront of the legislative, kind of the organizational standpoint of improving the healthcare of our rural Texans. I want to thank the attendees for joining today's discussion. And if you want to learn a little bit more about what Molina is doing in the community, you can look us up at molinacares.com. And again, thanks everybody for a wonderful discussion today. Have a wonderful day.
Thank you.